My name is Leanne Larange, and I'm speaking to you today from Edmonton. I would like to begin today's webinar by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many to live healthy lives on this land since long before settlers arrived. And with that, we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today, and encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. And now it is my pleasure to introduce this morning's speaker. Dr. Pamela Roach is a member of the Métis Nation of Alberta and an assistant professor at the University of Calgary, Department of Family Medicine, and director of Indigenous Health Education at the Cumming School of Medicine. Dr. Roach's research program addresses the overarching theme of cognition and brain health in Indigenous populations to enhance equity in populations-based health outcomes. This work includes understanding the social drivers of cognition and brain health for Indigenous populations, and she also contributes to Indigenous health and anti-racism teaching in the Cumming School of Medicine. So welcome, Dr. Roach, this morning to speak to us on the topic of Indigenous health and health equity. Over to you.
Thank you so much, and thank you everybody for joining this morning. I was really pleased and honored to get the invitation to come and talk to you. So I don't often get to talk to some of different professional groups. So really looking forward to our time together today. And I think just to kind of set up what we will be talking about, it's a fairly broad conversation about Indigenous health and health equity in the healthcare system in general that will hopefully give you some pieces that you can reflect on further. And I'll just say thank you to Leanne for the introduction and the land acknowledgement. And I'm joining you from Treaty 7 territory. So I'm down in southern Alberta on the lands of the Blackfoot Confederacy, including the Siksika, the Kainai, the Piikani, and also the Tsuut'ina and the Stoney Nakoda First Nations, and on Métis Nation of Alberta Region 3 area. I am a member of the Métis Nation of Alberta, but I originally come from a little Métis community in Manitoba called St. Laurent, right on the shores of Lake Manitoba. So although I've grown up mostly in Treaty 6 and Treaty 7 territory out here, I do acknowledge that I'm still a visitor on these lands as well. So maybe I'll just go ahead to some of the things that I'm hoping we'll achieve this morning. And really it's sort of understanding those experiences of racism faced by Indigenous people when accessing health services, identifying the potential impact or implications of racism on individuals' willingness to access care and both individual and community level health outcomes, and apply some strategies. And those strategies today are mostly going to be, giving people tools to reflect on our own positionality, our own role within the health system. I will share a few thoughts before we start. Sometimes when we talk about Indigenous health and health equity in the system, you've seen the learning objectives. I've already used the word racism, and it's really impossible to talk about the things that we need to address within the health system without talking about how racism plays a part. And I realize that makes people uncomfortable, but that's okay. So, the learning happens when we do feel uncomfortable, and we'll feel uncomfortable together. It can be an intimidating space to ask questions. So if there's a way, I think Leanne will be able to help with that, to send questions anonymously to me. That's okay too. I realize we're not on camera this morning, but if you need to take a break and a pause because it's a bit heavy, that's okay as well. And I will just ask that, remembering we don't know who else is on the call, that questions and talking openly, those are good things, but let's make sure that we do those things in caring and compassionate ways that are respectful of everybody's lived experience as well. So I think I just want to give us some common language before I carry on with the presentation, and I think this is a really important thing to do because We've seen, particularly since the murder of George Floyd and the resurgence of Black Lives Matter, that there's a lot of talk, there's a lot of more dialogue within media and within our workspaces about racism, about systemic racism. And I think it's important to make sure that we're clear about what those concepts mean, just because sometimes I think, especially when we talk about systemic racism, it's sort of portrayed as this idea that within a system there's just lots and lots of racist incidents that happen, and like people being racist. And actually what we're talking about when we talk about those kinds of things is actually a system and a structure being constructed in a way that actually discriminates based on race. So I wanted to give us a little bit of common language here, just so that we're clear about what we're talking about. And this comes from the National Collaborating Center on Aboriginal Health, and really just defining racism as a belief or doctrine that there are inherent differences among various human races that are cultural or individual, that determine cultural or individual achievement. So in Canada, that is very highly intertwined with this idea of settler colonialism, and this idea that people of European descent were inherently better. And there's lots of structural and historical reasons of why those beliefs were held. But we see them play out in the current day in different forms. So I'll just address quickly a couple of different forms or levels of racism. The first one is probably the one that we're most comfortable identifying and we're the most comfortable seeing and spotting. And these are the ones that we're trained to intervene on, which is relational or interpersonal racism, which is that context of everyday human relationships and the experience of discriminatory behavior. So these are things like slurs, racial epithets, violence, exclusion. We can see those things happening, and it's easy to identify them and name them. What becomes harder to name is that idea of structural or systemic racism. So that's that idea that it's the structure, it's the institution that is set up in such a way that people are advantaged or disadvantaged based on the way the structure is set up. And so when we think about the health system, there's very clear examples of this. There's jurisdictional issues, so people who live on reserve or have treaty status will access healthcare in a different way, and they may access healthcare through federal non-insured health benefits. There's different services or regulations that are available around Jordan's principle for First Nations children that are not available if people are off reserve or don't have treaty status and then cannot access health in the same way. And so, when we think about all of these kinds of things within the health system and that safety lens, there's actually all of those instances of interpersonal racism, but then there's all of these structural and systemic barriers that are set up to disadvantage people as well. And then I'll just kind of briefly mention that last line. That is something we call epistemic racism, which I see very prevalent in higher education and in medicine, which is the dominance of Western knowledge systems. And so we often talk about evidence-based medicine, but when we do that, we're actually only talking about Western evidence-based medicine. So I see this play out a lot in the realm of science and medical education and academic medicine. And then just to kind of show how that plays out around social determinants of health. So this is taken from a companion document to the United Nations Declaration of Rights on Indigenous Peoples. So there's another document called the State of the World's Indigenous Peoples, and it's around health. So I would urge everybody, if you check out UNDRIP, which is that United Nations Declaration, to also check out the accompanying health documents. And we talk a lot about social determinants of health. And this sort of tries to illustrate Indigenous determinants of health, so that those typical social determinants of health are important, but then we have different compounding and layered factors, including things like colonization, Christianity, urbanization, and globalization that compound onto the experience and the health outcomes of Indigenous people. And when we think about how that manifests then in our health system, we think about anti-Indigenous racism in health, and there's been a number of documents. So you can see there's a few documents there that I would encourage anybody to check out if you haven't already, that illustrate over and over again the the extent of anti-Indigenous racism in healthcare. That picture in the top right corner in plain sight was a report released in October 2020 from British Columbia on the back of reports of the Price is Right blood alcohol betting game that was happening in emergency departments. And so they spoke to just thousands of people about their experiences of racism in the healthcare system. And you could replicate, in my opinion, that report in any jurisdiction within Canada and get similar results. And it's quite shocking to hear some of these things. And I will say the way I've kind of moved towards my own research more recently is to recognize that these experiences are really important. It's really important for us to hear the experiences that people have of anti-Indigenous racism in the healthcare system, while at the same time that allows us to externalize the problem and shift the responsibility of the problem to other people, because we can look at that data and say, that's really terrible, but I'm a good person and my colleagues are good people and we don't know where this is happening. So on that end, we've recently completed a survey that should hopefully be published soon around anti-Indigenous racism and bias held by physicians in Alberta, where we actually surveyed physicians around their bias. And, you know, the results of that, perhaps not shocking, but still disappointing, that a significant number of people were, you know, expressing anti-Indigenous bias, and these are people who are within the healthcare system. So I think acknowledging that the problem not only is being experienced, but we can start to think about who's perpetuating that. And then beyond those reports, we actually even see multiple headlines. I update this slide. This is a slide I use for teaching quite a lot, and I update it fairly frequently, and there's always more headlines. And these are the stories that make it to the news. These are the stories that get told, and these are the ones that we hear about. And for every story that makes it into a headline, there'll be dozens that don't. And these stories are everything from, there's that BC hospital staff accused of betting on blood alcohol levels story down in the bottom left corner. There's child apprehension. There's birth alerts that are still happening where Indigenous infants are being apprehended, you know, a few hours after birth for unjust reasons. There's lots of examples of people being treated poorly in hospital. There's been recent claims in British Columbia of children under the age of 10 being fitted with IUDs because they are experiencing sexual abuse in foster care, and instead of being, you know, thinking about how do we shift the system and move those children back to the family or community environments, they're actually just being fitted with IUDs to prevent unwanted pregnancy because of the abuse. And so these are shocking and really impactful. These are things that will have a huge impact on people's lives. And we're all part of this system. So this is why it becomes really, really important to have that systemic lens when we're looking at things. And then I would be remiss if I don't talk about some of the very direct, high-profile cases that we have seen. So I'm sure many of us have heard of Brian Sinclair, who was 45 when he went to a Winnipeg emergency room because he had a blocked catheter and he had a treatable bladder infection, and his family doctor sent him in there with a referral to get his catheter cleaned out, and was ignored in the waiting room and was ignored for hours after he had died as well while waiting for treatment. And then obviously the memory of Joyce Echequan, who was 37. So she's younger than I am. She had 7 children. And in her final moments of experiencing racism within an emergency room in Quebec, actually live streamed it to her Facebook so that people could bear witness to what was happening. And there's been some significant movement and shifts and changes within the health system to improve things because of this, but we need to recognize that these things are happening every day to Indigenous people within the health system. And I would say if you want to explore, especially as it's an Alberta audience, the Alberta First Nations Information Governance Centre has a lot of data on their website, so I would also encourage everyone to take a look at that. And they have these one-pager health trends, and so you can look at a multitude of different conditions. So if there's particular areas, they have things on injury and those kinds of things. You can check that out and take a look at the actual data for the province. This one I find is important to share because we can see that the gap in life expectancy between First Nations and non-First Nations people in the province has actually widened to just under 12 years. So previously, I think about 15 years ago, it was about 8 years of a gap, and now it's widened. And so I think despite the education that we have and we do more Indigenous health education within the health system, there's some larger scale systemic changes that need to happen to really be able to have an impact on some of these outcomes. And then I would also point everyone to some data from the province as well. Some colleagues at the University of Alberta and here at U of C have done a large-scale piece of work looking at emergency care. So there's a number of papers that have come out about that around First Nations experience in the emergency room and things that prevent people from accessing care. And I think from a physiotherapy point of view, these are, if people aren't accessing care, a lot of people will access the emergency room because of a lack of primary care, and then will avoid care, so that may have an impact on potential physiotherapy needs down the road as well. There was a more recent paper that came out in January of this year that actually quantitatively evidenced the fact that First Nations people are triaged at lower scores than non-First Nations people when they access emergency room care. So it's really important. It's not just a case of saying like, well, people are subjectively saying they're being treated poorly, but we actually have measurable differences in the way that they're assessed and triaged. So I guess you're probably wondering, well, that's a little bit disheartening to hear all of these things and these things that still happen and are still very prevalent within the healthcare system. And what do we do about it, right? What is everybody's role in working together on this? And what I would say is most public health agencies are starting to recognize that racism within the healthcare system is a pandemic. So this is a picture from one of the Black Lives Matter protests in 2020, just advocating for change, that this is something that we need to address as a society. And so to that end, the Canadian Public Health Association, even as far back as 2018, was publicly stating that racism is a public health issue in Canada and that we need to take action. Similarly, the CDC, the Centre for Disease Control and Prevention, has joined lots of cities and counties across the United States. So in 2021, the CDC director called racism an epidemic that affects the entire health of the nation. This is just a screenshot. This is a really interesting website, so if any of you are interested to explore the data some more, I encourage you to go check it out. But the American Public Health Association actually has a map of all of the cities and counties and areas in the United States that have declared racism as a public health emergency. And so you can look at all of those things, and it's interesting to see where it's happening and where it's not happening. And so what does that mean for us in Canada? So in Canada, we know we have the Truth and Reconciliation Commission of Canada's final report and calls to action. This is the National Centre for Truth and Reconciliation that's housed at the University of Manitoba, and the website is there for you if you'd like to go check that out. And this is another thing I would encourage all of us to think about and to go look at. And so you can engage with this website. I would encourage everybody to read the Truth and Reconciliation Commission of Canada, the calls to action. So at a minimum, read the calls to action. And then if you have the time, there's a number of volumes of the full report, and so maybe start taking a look at those. But at a minimum, take a look at the calls to action. There are 7 health-related calls to action that I'm going to go through with everyone. But I think, there's many more, and there may be more that are relevant to different areas of your life as well. I always encourage people, if you have children and you're involved in their school or their sports, there's sports-related calls to action, there's education-related calls to action, depending on where you work. The children and family services kind of components, social work components may be more relevant. But you can definitely sort of take a look at those calls to action and find out where you fit and where you could make a difference, where you could perhaps advocate for change in your local sphere of influence in work, or just in your working day-to-day life as well. And so what this website will take you to, this link here on the slide, is actually a map of all of the residential schools in Canada. So there was, I think, in the TRC, I think it was 137 recognized residential schools in the country. And so those are actually only the ones that are recognized by the federal government, that were funded by the federal government and included in the TRC. We do know that there's a number of schools that if they were funded privately by churches, so those would not have been included in the TRC. They were ones that were federally run only. So although we have like 137 recognized residential schools, there were much more, and there were also day schools. So there were schools where First Nations and Métis children went, and Inuit children went, that they would go home at night, but they were still subjected to similar treatment in the daytime at those schools as well. So what you can do is go take a look at the map. If you're wondering, you know, what were the local residential schools that were near to where I work now, Alberta actually had the highest number of residential schools of any region in the country. So you can take a look at that. If you have lived in other places in Canada previously, you can also look and see what some of the schools local to those areas were. And there's reports. You can read reports from the time, so like historical reports of the people who ran the schools, and read the stories of the children who went there. And there's photos, and I think sometimes that's a much more impactful way to connect to the reality of the residential school system in Canada. And we know that a very small number of schools have been investigated so far for mass grave. And we also know that there is over 10,000 potential children that we've found so far, that we've recovered so far, out of about 10% of those schools that have been searched. So I often think about how different our current society would be if all of those people had not been taken and were here and had children and grandchildren and cousins and aunts and uncles and all of those people who should be sitting around our table. So on that note, I want to kind of take us through together to the calls to action. And the reason I start with the residential schools is because it's really important. Call number 18, which is our first health-related call to action, really calls upon all federal, provincial, territorial, and Aboriginal governments, which I recognize as, you know, the health system being publicly funded plays a role, right? So whether we're in education or whether we're in frontline healthcare or administration, there's a role to be played there and an obligation to answer these calls. So call number 18 asks us all to acknowledge that the current state of Indigenous health in Canada is a direct result of previous Canadian government policies, and I would actually add current Canadian government policies, including residential schools, and to recognize and implement the healthcare rights of Indigenous people as identified in international law, so things like the United Nations Declaration, constitutional law, so that's our own laws in Canada, and under the treaties, which have not been negated by any legislation, right? Those treaties are still in effect, and still there's an obligation to uphold them. Call number 19 asks us to establish measurable goals to identify and close gaps in health outcomes. So there's work there, like the Alberta First Nations Information Governance Centre. There's a federal body that does the same thing. In Alberta, much of the Métis Nation data, health data, is housed at the University of Alberta. So there's people working on being able to establish measurable goals through the collecting of that data. Call number 20 is to address jurisdictional disputes concerning Indigenous people who do not reside on reserves. So looking at how do we address those healthcare needs of Métis, Inuit, and off-reserve First Nations people. So how do we do that? And many Indigenous people now live in urban centers, so that may restrict the healthcare avenues that people could typically explore. Call number 21 is to provide sustainable funding for existing and new Indigenous healing centres, particularly in the North. Call number 22 is about affecting change within the Canadian healthcare system to recognize the value of Indigenous healing practices. And so that even speaks to that epistemic racism that I had mentioned, right? And so thinking about how do we recognize the value in our spaces, in the way we interact with patients, in the way we educate healthcare professionals, and making sure that we're not discounting years of culture and inherent knowledge in how to live in a healthy way because it doesn't fit into a Western model. And then finally, these last two calls to action is sort of why I'm here today and part of a large part of what I do in my own working life. And so call number 23 is about increasing the number of Indigenous professionals working in healthcare and ensuring the retention of these people in Indigenous communities, and to provide cultural competency training for all healthcare professionals. So I do a lot of training and education and student support, and how do we support Indigenous learners in all healthcare professional education. And then call number 24 is specific to medical and nursing schools, but I think I take a very broad approach to this as far as all the allied health and all healthcare professional education, but to make sure that people are learning around the specifics about Indigenous health issues, including residential schools, including the United Nations Declaration, the treaties, and really doing skills-based training, and I would say in cultural safety, not that we can ever become competent in other people's cultures, but looking at conflict resolution, human rights, anti-racism, so being able to give people the skills in their educational pathways to address these things. And I think an important part of that for me is talks like this, because I know even when I did K-12 education, I went through the school system here in Alberta, and we learned very little about anything about Indigenous peoples, and what we did learn was very surface level, and in some cases, from my own experience, very harmful. And I do know that many people, depending on when they trained, if you're a healthcare professional, may not have had a lot of education on this. So I see that continuing professional education and development as an important piece here. So then I'll just maybe direct you to a few other reports and directives that you can take time. I've put the links there on the bottom so that you'd be able to find these resources. But in 2019, a report came out called Reclaiming Power and Place, which was the Murdered and Missing Indigenous Women and Girls and Two-Spirit Peoples report, and there was 231 calls to justice. The ones that are related to health are very similar to the TRC calls to action around Indigenous-led healing services, training healthcare professionals, education in Indigenous health and anti-racism, and similarly that In Plain Sight document that came out in 2020 from BC again asks us to implement an Anti-Racism Act. We need to align our actions with the United Nations Declaration. We need Indigenous leadership in health professional education and in all health professions, right from people on the front lines up to senior leadership. We need to recruit additional Indigenous health professional learners and improve safety. And so that's not even just safety in the healthcare system, but if we want to recruit and retain Indigenous health professionals, our education environments need to be safer as well. And then the last sort of document I'm going to talk about and give you a link for is one I've mentioned a number of times. So it's the United Nations Declaration on the Rights of Indigenous People. This was released by the UN in 2007, and it was ratified by the General Council in 2008. And at that point, all of the UN voting nations voted to adopt it, except for 4. So those 4 nations that voted no to adopting the United Nations Declaration to enshrine the rights of Indigenous peoples, right? So the minimum standards for survival, dignity, and well-being of Indigenous peoples around the world. Those 4 countries that opposed it were Canada, the United States, Australia, and New Zealand. And I think, it's important to really think about that, because the Canadian Constitution, the government, the state, is really set up as a resource-based state. It's a resource-based economy, certainly here in Alberta. And the United Nations Declaration really firmly entrenches the rights of Indigenous people to have self-determination, self-governance, and all sort of free and prior consultation on resource extraction, and also that Indigenous peoples have the right to be free from discrimination and the right to a nationality. And so that creates a series of important conversations between First Nations, Métis Nations, Inuit people, and the Government of Canada. So I think the U.S., Australia, and New Zealand were facing similar conversations. I will say that Canada in 2015 did agree to aspire to adopt the principles of UNDRIP, but has since now actually voted to try to implement it. So there's a number of bills that are being written and attempting to be passed and being discussed in the House of Commons around what this looks like. And so it's really important to maintain Indigenous leadership and voices in those conversations. But that is essentially when we're talking about self-determination, whether it's in education or whether it's in the health system, the United Nations Declaration really fundamentally demonstrates that self-determination and self-governance is what makes Indigenous people healthy, and then those rights to that freedom. And then again, this is an example that I hope kind of pulls it all together for everybody today, looking at good health and wellness outcomes and how we think about that and how we conceptualize that. And then those different impacts. So there's colonialism there, there's things about the healthcare system that create these negative impacts. So there's stereotypes, discrimination, poor access to healthcare, and then poor outcomes. And how do we interrupt that? And actually we can work on the front lines to address those poor health outcomes and address accessibility and try to educate people about discrimination and stereotypes, but really the way we break the cycle, the way we have a true impact in improving outcomes is a systemic change that happens more upstream. And so that's where we have Indigenous systems and self-determination and practices and self-directed health systems. And so when we're thinking about Western context, recognizing that we may not have fully self-determined Indigenous health systems in every space, it's really important that we are guided and led by Indigenous people when we're designing, or even thinking about if we have systems already in place and services already in place, how do we make sure that those services are meeting the needs of Indigenous people from their own way of knowing and from their own Indigenous lens and worldview. And so that becomes really important. So that's another big piece of the work that I do, is sort of that idea of how do we make our Western health services safer and in a way that we can kind of bridge those different ways of knowing, so we can understand Indigenous patient views and then translate that into a way that our Western healthcare providers can understand and then adapt to their practices, right? So that adaptation of continuous quality improvement. So to wrap up, because I did want to make sure we had a fair amount of time for conversation. I find generally there's a lot of questions to talk about. There's a lot of things to think about, and when we think about our own practice and resources, what we can do better, there generally is a lot of conversation. But before we get to that, I wanted to give you a couple of tools where you can start reflecting and you can start thinking about these things. So the first one, the Canadian Medical Association last year released a video called The Unforgotten, and there's the link at the bottom there. It's actually, it's a 30-minute video, but it's broken into sort of 6 5-minute chunks about the lifespan. So there's birth and childhood and youth and adulthood and elderhood. And then there's a series of reflective, self-directed, reflective questions that you can think about after you watch it. I will say, from my own point of view, the video is excellent. And if you can watch it, if you have half an hour to watch it all at once, that's great. I found parts of it, just from an Indigenous point of view, very triggering. So I think if there's Indigenous people on the call today and you haven't watched the video, I think, make sure that you have the supports that you need, because there's some pieces that may be fairly upsetting. I think it's good, especially then for non-Indigenous healthcare professionals, to really watch that and deeply think about it. And this is where I'm talking about that discomfort that spurs us to make change. So I think if anything I've said today makes you uncomfortable, or you want to have a think about watching this video and that makes you uncomfortable, I think that's kind of a positive thing, that we can settle into that discomfort and think about why does that make me uncomfortable, and what can I do to change it. And I often liken this to, it may be uncomfortable to watch a 30-minute video or hear me talk for 45 minutes, but Indigenous people trying to access healthcare are not only uncomfortable but unsafe just about every day in the healthcare system. So just thinking about where we go from here and what we do next. So there's a number of ways there to advocate for the necessary changes in Canada's healthcare system. So that you can check those out. And there's some different reflective tools. There's lots of resources there. And thinking about our own learning together. And then the last thing, I think it's the last thing. Oh, I've got one more slide after this one. Is just a couple of tools from the literature that I actually find really useful. And so this one here, there's a paper you can access. If anyone has trouble accessing it, I can always share it with Leanne, and that can get passed on. But there was a scholar, she's American, and this came out, I think it's 1989, and this is particularly about sort of white privilege and male privilege, and the author's name is Peggy McIntosh. But this idea of privilege, I think, also is important to think about. And I sometimes feel that when I hear resistance to the word privilege or the concept of privilege, people say, I've worked really hard. I didn't have a lot of privilege. I didn't have a lot, my family weren't wealthy when I was growing up, and those kinds of things. And absolutely, nobody's discounting anybody's ability to work hard. It's more thinking that we all have this invisible backpack that we carry around, and within that backpack, there's different things that afford us different advantages or different opportunities that other people don't have in their backpack. So there's a series of statements there, and there's a whole number of them. I didn't even include all of them on this slide, but there's a number of them that you can go through and think about. Some of these things, like, are these things I actually have to worry about? Right. So even things like I can, if I wish, arrange to be in the company of people of my own race. When I go to a meeting, I can expect that I will see people who look like me. And I can say, as an Indigenous person working in academic medicine, that's, I have some amazing colleagues, and I love that when we're in meetings together, but most of my meetings, I'm the only Indigenous person in that room. I can be sure that my children will be given curriculum materials that testify to the existence of my race or their race. This is a big one for me of late, with different, movements in education in lots of realms. But certainly Indigenous erasure happens a lot in all of our post-secondary education and continuing professional development. But children often don't see themselves reflected in curriculum. I can be pretty sure of having my voice heard in a group in which I am the only member of my race. That is, in my own experience, that does not happen for Indigenous people. So I think it's thinking about those things, like when somebody's entering a healthcare space and perhaps they're the only Indigenous patient, or they're going into a healthcare space and all the professionals are going to be non-Indigenous, and they're there, that immediately sort of creates an environment which feels potentially unsafe, it feels risky, and you're not sure about how that's going to go. And my own experiences of accessing healthcare reflect that too. So that just is, it's a tool, it's especially for people who maybe are coming to this fairly new. It allows you to start thinking and exploring some of these things, right? That if I pick up a newspaper, I can see stories about people who look like me. And that maybe those things, not everyone has every item in their backpack that everyone else has. So that's a tool. And then the last thing that I will leave you with is this. Again, there's the link. This is a really great pocket guide to anti-racism, and this is more for those interpersonal instances of racism that you may come across. So you can literally print it out and cut it out and fold it up, and it fits in your pocket. It's like a teeny little piece of paper, and essentially it gives you some different lines, like, oh, you know what, that's just not the way we do things here. If you're working in a team, so if you're having your team huddles or team meetings, and somebody says something, you can say, oh, that's actually just that's not part of our team culture here. And it gives you a different strategy. So I often suggest, choose a strategy, choose a line, a little script that feels comfortable, that you could start testing out when you see things happening. And then when you get comfortable with that one, choose a second one and start trying to test that one out. And depending on the context, you may need to have a few different ones in your pocket, but it literally gives you something to keep in your pocket to help out in those challenging moments. So I think maybe I'll stop there so we have time for questions. And I know that this was a very, very broad overview of some of those experiences of Indigenous people in the healthcare system, which I hope has been helpful and at least gives everybody a starting point to start reflecting on some of these things.
Thank you very much. That was an excellent overview. I particularly like this last resource in terms of disrupting comments or statements made by others. I'm wondering if you are able to elaborate a little bit on the study that you mentioned around biases in Alberta doctors, because I wonder if there's you didn't say it directly, but I'm wondering, is there both sort of explicit statements and also sort of inherent bias that people carry, and that was evidenced in the research?
Yeah, absolutely. So that's a great question, and I've done whole separate presentations on that data because it's fairly new, and we actually are trying to find a home for the actual paper, so then we can distribute it more widely. The survey in general, that also included some demographic questions and things, has been released, and the CPSA released a report. So they were one of our stakeholders, and so they released a report that is publicly available that has a little bit of the information, but not the full data. But what I can say is we did ask questions that measured explicit and implicit anti-Indigenous bias. So the explicit questions one was how warm do you feel towards Indigenous people? And it was just a sliding thermometer scale, so people had to click on the thermometer and physically slide it to where they wanted it to be. Did they feel warm or did they feel cold towards Indigenous people? And then the second question was, do you prefer Indigenous people? Do you prefer European people or Indigenous people? And again, that was a slider that they clicked and slid. So it was very, I always think it's not just like somebody was like doing a checkbox. It was like a physical, I need to actually move this slider. And those questions, there was, I think, out of the people who answered that second one around preference, 25%, so a quarter of the physicians that answered that question actually said they preferred European people over Indigenous people. So it was quite a lot, and some of the comments on some of it say, well, was it really that many? And I'm like, well, when we see the really drastic and sometimes horrific outcomes that Indigenous people face within the healthcare system, it's really important that those are people who are potentially causing harm and potentially causing death to people trying to access healthcare. So yeah, it is important that we it might not be the majority of people who are expressing those opinions, but it's really important that we're able to try to find out more about those physicians and how do we remediate that, how do we fix that. Sometimes people say, well, I'm sure it's like older physicians and they'll retire and things will be better. And I personally, I don't know if that's the answer. I think that it's a quite pervasive, and not picking on any particular professional group, but just in Canadian society, right? So I am fairly white-coded as an Indigenous person, and so if people don't know me, sometimes they will assume I'm not Indigenous, and I've heard some pretty horrific things said, and I think it's just a very pervasive narrative in society. And then the other piece of that was also measuring implicit bias. So we did an implicit bias test, and I don't know if anybody has done any of them. Harvard has a number of them. Harvard has like a black-white implicit bias test, and this one was developed by people out in Ontario, and it's an Indigenous implicit bias test. And there were high levels of implicit bias, but at the same time, I think, I always say with implicit, that's more of an indicator of the society, right? Because that's something people are socialized to have implicit biases, and so that's something that we can start working on. But it's a bit different when people are explicitly moving a slider to say, yes, no, I don't like, I feel cold towards Indigenous people. So what we're hoping to do there, although the results are anonymous, obviously, we did ask some demographic questions around area of work, if people, what kind of geographic location they live in, if they're in a city or if they're in a rural or remote area, are they academically affiliated? So what that will hopefully do is give us some places where we can target more educational interventions and those kinds of things. So we actually found that people who are working in remote areas have lower levels of bias, and people working in urban areas with academic affiliations have expressed higher levels of bias. So that gives us an idea of where to maybe more intensely do education initiatives.
And I was thinking it would also be good for us each to look at those implicit biases, those questions that are reported on, and reflect on whether we can identify those in ourselves and disrupt them in ourselves.
Yeah.
For those of us who are not Indigenous, I should say. I have a question here from Cheryl, and it's a bit along the lines of a question that I had around Indigenous healing practices and how clinicians can, I'm not framing this very well, what are the building blocks that people at the point of care should think about in terms of incorporating or recognizing Indigenous healing practices in their day-to-day work, just recognizing that this audience is a point of care audience. So how could we begin to think about doing that as practitioners?
Yeah, and that's such an important question and a really interesting question. And I guess knowing that this is sort of a provincial audience, I know like locally we have in Calgary there is an Indigenous clinic. There's a Elbow River Healing Lodge. I think that there's an Indigenous wellness clinic in Edmonton. And then there's also because of the pandemic back in 2020, an Alberta Indigenous virtual care clinic opened. So I guess what I could say is that if people are looking to explore connection to traditional healing practices, it's sort of finding out, I think the virtual care clinic is a great place. It's primary care, so it's a great place to kind of connect people, and maybe they'll have resources based on where someone is actually living. But it's a good question, and I really see a need for more accessible places, especially in urban settings, because I think people who are maybe disconnected from their culture and for a whole host of reasons, and around colonialism, and when there was the 60s scoop where children were taken from Indigenous families and placed with non-Indigenous families, and then may or may not have been able to connect back to their own community, who have been disconnected from their culture and from those practices. So I think it's you can always ask the question if a patient is saying that if they've disclosed that they're Indigenous, certainly asking are traditional practices important to you? How can I help you? What is important for me to know? And some people may not want a connection to traditional healing, but some people might, and then it's sort of reaching out to those places. There's also the Indigenous Wellness Corps through Alberta Health Services. And so there's sort of a central point, particularly for people who may not be on community. And then if people are living like on reserve, or if you're in a working in a health center that's on reserve, then hopefully there will be people in those places as well that can connect people to traditional healers. I think as someone who's not a traditional healer, I can't like pass on any information about any of those practices, but I think it's an interesting conversation, and I think it's an important conversation to have, that we need more of those people. We do need people with traditional healing knowledge to be more integrated into the health system, so that when healthcare professionals are interacting with patients and they express that desire, we kind of know where to go, and then we can have more education on that. And part of my work within the medical school as well, and sometimes I go and I end up in other faculties and doing other pieces of education, is addressing that epistemic racism piece, where we talk about what is evidence-based, and just because something may not be a biomedical model doesn't mean that there's not evidence for it. So some of it is challenging some of those views as well.
Lots of questions coming in, and I'm going to sort of try again to cluster them. So we have had a few people asking about how to build connection to communities, like, for example, in their local area, if they're seeking to build connection. Are there any best practices that you're aware of, or worst practices that you're aware of that clinicians should avoid if they were seeking to build connection to their local community, or wanting to seek to better understand health services in a local community?
Yeah, that's a great question. I think many. So if we're thinking about on-reserve communities, some communities have their own health centers, so like that's a great place to start and to start building those relationships and seeing what the needs are. I think sometimes, even from my own point of view, I think I can think of an idea and think, this is great, I think this is a really important idea, but if it's not what the community is, and if it's not their highest priority, it doesn't matter what I think, right? And so going and trying to make those relationships and build those relationships and find out what those community priorities are becomes really important. And I'm just thinking, and within urban settings as well, like there's plenty of Indigenous healthcare providers. It's kind of figuring out where people are. And sometimes, I often get emails from healthcare professionals out in the community, just thinking like, hey, I want to do what I can. I want to lend my skills and my practice to doing things in a good way. Where do I start? And then I might put them in touch with like a community-based physician that I happen to know, and then they can start connecting to other people and seeing where the needs are. So certainly I think, reaching out to people like that is great. So if you're in Edmonton, you can look at who the relevant people up there are. I'm trying. I think often like there's, many Indigenous physicians become leaders and are quite prominent. So you could always reach out to people to find out, how do I do this in a really great way. There's different groups that prioritize Indigenous health. So for physician groups, we have a different sort of stream of physicians who are trained to specifically provide care to Indigenous people in different contexts. And like as far as like worst practice, I don't want to discourage people from getting involved because of the fear of making a mistake. We all make mistakes, but I think not building the relationships, right? It's really important to be community-led and community-driven, and finding out what the priorities are, and building some relationships there, and figuring out where do I fit, what is my role, and what can I come along to and offer support when I can. So it's sort of looking around for the people who are already doing the work and then taking your cues from them.
Thanks. That's a great answer. I like the community connection piece, because I think that I've read that and heard that from many sources. So thank you. That's a great highlight. I have had another individual asking about cultural competency, cultural safety. I've heard both of those terms, but I guess two parts to this question. The first is, as working clinicians, no longer in the entry to practice education system, where would a clinician go to develop those skills of cultural safety and cultural awareness? And then as a clinician who was seeking to develop a service that was more culturally safe, how would they know if they were succeeding in doing so?
Very good questions. That last one is a pretty is a big one. So I guess, first of all, for people who are connected to Alberta Health Services, there are some online modules, and it is, it doesn't go super in depth, but it's a huge thing, and I think a lot of my work actually focuses on things like continuing education for healthcare professionals and for faculty development. Because I recognize that we can build this stuff into the education, the curricular education that we provide to learners now, but we also need people who are already practicing and who are interacting with learners and who are interacting with patients to have this education that they maybe didn't get to the same extent. So that's a really good question. So there are some online modules there. I think for a general overview of Indigenous history and Indigenous sort of historical and contemporary issues, there is, through the University of Alberta, an online course called Indigenous Canada, and that's it's called a massive online open course, so we call it a MOOC, and that it's not health specific, but for people who are new to learning a lot about these things that maybe they didn't get exposed to in their own education, like post-secondary even. It's a good baseline. It's a good sort of foundational course, and it's free. You can pay, I think it's about $65 for a certificate of completion, but you don't have to, and it's free, and it's self-directed, and you can do it at your own pace. So that's a good starting point. There's other things. There's a course called SANYAS, which is S-A-N-Y, or Y-A-S, sorry. And that's a good course around some of the specifics that Indigenous people face within health. If you're involved in research at all, the OCAP, the First Nations Information Governance Center, runs a self-directed learning course on OCAP. And then for anyone who's connected to universities, typically there are some learning modules or things that you can sign up for through different educational institutions. But I think, a lot of it, I just see such a need, and I can't speak directly to what some of the other health professional organizations and colleges offer, but there is definitely a need. So I think, you can start to access some of those things, and then maybe follow, I don't know if there's newsletters and social, I follow a lot of people on social media, and so I see events pop up, and I will attend different events offered by people, and I think now that we're in a much more virtual world, there's a lot of events that people do across the country that we can join to try to quickly answer that. How do we know we're doing it well? And just to quickly also differentiate. I find cultural, I think it's more of a language shift. That we used to say cultural competency, but I think more and more people are recognizing that we can't really, say that people are competent in another culture. And so it's actually more about safety. It's about increasing safety within the healthcare system. So that's why there's sort of this shift to that language. And how do we know we're doing it? I'd like to say that we would see better health outcomes, right? We would see better healthcare outcomes for Indigenous people within the healthcare system, less harm. But part of the work that I do is actually to make it a little bit more concrete and tangible. So we can look at health outcomes, and we have fabulous people in the different organizations sort of measuring that, which is great. But then also doing things like how do we look at creating patient experience measures that actually are based on an Indigenous worldview, where people can share their experiences. And so that's part of the work I do in various different sort of clinical areas to be able to translate that for Western healthcare providers so that they have a way of that sort of immediate feedback and ongoing clinical improvement.
Do those patient experience measures already exist? Are there ones that physiotherapists or other frontline clinicians can go and look at? Because it seems to me that looking at health outcomes, obviously the objective long term, but that's a very long term goal. So the patient experience measure might be a metric we can use in the near term.
Yeah, and there's some frameworks.
So first question, is that a fair assumption? And then from there, are there tools?
Yeah, absolutely. And there are some frameworks that exist. There's an Educating for Equity framework, and there's some Indigenous health quality frameworks that we can look to. The one that we're just trying to get it out the door as far as publishing, so we can start like disseminating it and sharing it. But was developed with the virtual care, with that shift to virtual care through the pandemic. So actually developing a Indigenous virtual care patient experience tool. But once we've got that, then we can look at, is this relevant for other contexts? Can we adapt it to other contexts? And so that one, we're actually looking at implementing it into the virtual care, the Indigenous virtual care clinic in an ongoing way, just to become part of their ongoing clinical improvement. But I think once, we start doing more and more of this work, then that's the kind of information that gets shared, and we can think about, is this relevant for physiotherapy? And if not, what other kind of, what are the other concepts that we need to include, and how can we adapt things?
So I have one last question, and this is very much, I think, framed at that personal level, so thinking in terms of what we can do as professionals in care, but also thinking about what we can do as individuals in society. Lori asks, first off, she says, fantastic presentation, thank you very much. And then she asks, I believe you said Canada is still not supporting UNDRIP. How can we advocate to change that? And so I thought that might be a good
answer. So, so they have agreed to adopt it now, and so at the end of last year there was actually a number of different bills that were being written and discussed, and so some of those things, it's interesting because even though it's being adopted and supported, it's still making sure that whatever gets passed into legislation actually does embody those principles. As far as things like that, I would say the things that I don't know, I occasionally write letters to my MP and my MLA about different things. I'm not sure if it makes a difference, to be honest, but those are definitely things, right? Like if that's something we can write to our MPs about and just say that, I'm one of your constituents and this is really important to me. And I think, it's important for non-Indigenous allies and relatives, right, to join that and to say, I'm not Indigenous, but this is important and we need to recognize how important this is. So those are all those sort of official mechanisms to advocate for change. And then I think ways to see what's happening is if, you can follow news outlets, like Indigenous news outlets. There's a number of Indigenous reporters who are out there. APTN is an Indigenous news station. And it just gives you a different lens on many of the events in the world and in the country, and ways that we could think about addressing them. And I often get avenues of inspiration for advocacy from those people who are out there doing the work as well.
Awesome. Thanks for that. That's a great answer. It is just after 9 in the morning. We've covered all of the questions that are currently in the question and answer pod. Usually when I say that, we get a flurry of questions coming in at the end. But I think we will call the session to a close. And thank you very much for this excellent and thought-provoking presentation, Dr. Roach. And thank you to our audience for joining